Contraceptive implant. Contraceptive implant Nexplanon is a single rod implant that is inserted subcutaneously into the upper inner arm with the use of a local anesthetic. It is 2 millimeters thick and 4 centimeters 1.6 inches long and releases progestin continuously to provide 3 years of contraception. It acts to inhibit ovulation, thickens cervical mucus to prevent sperm penetrability, and thins out the endometrium, making it unfavorable for implantation. As with IUDs, increased use of hormone implants is recommended by ACOG as a means of offering effective, long-acting, reversible contraception. Implants can be inserted at any time, including immediately postpartum. Side effects of the contraceptive implant include irregular menstrual bleeding, as with other progestin-only contraceptives, acne, and minimal weight gain. Bleeding is expected and not a sign of abnormality, but irregular bleeding is the most common reason for discontinuation of the method. Amenorrhea may occur with longer use. Fertility returns immediately, and pregnancy can occur at normal rates when the implant is removed. The implant is often an appealing method for women who desire long-acting contraceptives but who may fear the discomfort related to an IUD insertion. Hormone injections. Depo-Provera, medroxyprogesterone acetate, DMPA, is an injectable progestin available in intramuscular and subcutaneous forms. It prevents ovulation for 15 weeks, although injections should be scheduled every 13 weeks. It is convenient and contains no estrogen. The action and side effects are similar to those of other progestin contraceptives. The IM form of Depo-Provera is given by deep IM injection. The sub-Q form is given in the anterior thigh or abdomen. The site should not be massaged after injection because massage accelerates absorption and decreases the period of effectiveness. No backup method of contraception is necessary after the first injection if it is given within 7 days at the beginning of the menstrual period. A backup method of contraception is used for 7 days if the first injection is given at another time or if the woman is more than 2 weeks late returning from a subsequent injection. It also can be given on the day it is prescribed if it is certain the woman is not pregnant, that she will use backup for the first week. Menstrual irregularities are the major reason for discontinuation, and women should be informed about this before beginning this method. Although spotting and breakthrough bleeding are common, amenorrhea occurs in 80% of women using the IM form at 5 years, and in 55% of women using the sub-Q form after 1 year. Other side effects include weight gain, headaches, depression, hair loss, nervousness, decreased libido, breast discomfort, and depression. A decrease in bone density occurs with Depo-Provera. Although there is an increase in bone density after the drug is discontinued, the effect on peak bone mass and risk for osteoporosis is not known. Therefore, current prescribing information states that Depo-Provera should not be used for longer than 2 years unless other methods of contraception are not suitable. It may be more of a problem for women who begin the drug during adolescence or young adulthood, however. The World Health Organization considers the advantages of use of Depo-Provera in adolescents under age 18 years to generally outweigh the theoretical risk for bone density decrease. Women using this method should obtain adequate amounts of calcium and vitamin D from diet or supplementation, should increase weight-bearing exercises. Depo-Provera can be started in the immediate postpartum period and will not have a negative impact on milk supply in lactating women. Effectiveness is not changed by a woman's weight. There is a delay in return of fertility after the drug is discontinued. Approximately 59% of women resume menses in 6 months. 25% do not resume menses for a year or more. Oral contraceptives, OCs, are drugs that inhibit ovulation. They are the leading reversible contraceptive method in the United States. They are available as COCs, which contain both estrogen and progestin, a natural or synthetic form of progesterone, and mini pills, which contain only progestin. Both types have much lower hormone levels than the original OCs from many decades ago, and therefore the risk for long term side effects is decreased. If OCs are used perfectly, 3 women in 1,000 become pregnant in the first year. Combination oral contraceptives. Estrogen and progestin combinations, COCs, are the most common OCs. COCs prevent pregnancy primarily by suppressing production of luteinizing hormone and follicle stimulating hormone, thus inhibiting maturation of the follicle and ovulation. COCs also may cause thickening of cervical mucus, which prevents sperm from entering the upper genital tract. In addition, tubal motility is slowed and interferes with sperm and ova transport. Monophasic or multiphasic dosages are available. Monophasic pills have estrogen and progestin content, which remains constant throughout the cycle. With multiphasic pills, the estrogen dose and progestin levels may vary at different times of the cycle. Because the dosage changes throughout the phases, women must take the pills in the proper order to maintain effectiveness. Patterns of pill use vary. Most COCs are available in packets of 21 or 28 tablets. With 21 tablet packets, the woman takes one pill daily for 3 weeks and then stops for 1 week, during which time menstruation occurs. Packets of 28 tablets include 21 active tablets and 7 tablets made of an inert substance that the woman takes during the 4th week. In some types, the placebo pills contain iron. The extra pills avoid disrupting the everyday routine of taking pills. Some formulations contain 24 active tablets and only 4 inactive tablets. Women using COCs have shorter, lighter withdrawal bleeding. Other COCs are designed to provide 84 days of active pills and 7 placebo pills, or 7 pills with just a small amount of estrogen. This allows women to have menses only 4 times a year. Some women prefer continuous extended cycles in which menses is delayed or does not occur. Women may wish to regulate their cycle for a special event or for preference of not having a withdrawal menses. These women take 2 or more pill packs without taking the placebo pills for several packs or indefinitely. Breakthrough bleeding and spotting are a common problem with extended or continuous use, but this usually lessens over time. A potential disadvantage is that a woman might not recognize an early pregnancy if it occurred. COCs can be used in the postpartum period, but according to the CDC, should be avoided in the first month postpartum because of the increased risk for thrombotic events. Progestin only. Progestin only pills, POPs, are taken daily with no hormone-free days. POPs are less effective at inhibiting ovulation but cause thickening of cervical mucus to prevent penetration by sperm. They also make the endometrial lining unfavorable for implantation. These pills avoid the side effects and risk factors associated with estrogen and are useful for women who cannot take estrogen. If a woman misses any pills or does not take them at the same time each day, the chances of pregnancy increase. Another method of contraception should be used for the first 2 days of the first cycle, unless the woman starts the method during the first 5 days of her cycle or immediately after stopping another hormonal method. Backup contraception also should be used for 2 days if the woman is more than 3 hours late in taking a pill or has vomiting or diarrhea. Breakthrough bleeding and higher risk for pregnancy have made POPs less popular than the COCs. Amenorrhea occurs in some women. Benefits, risks, and cautions. When OCs are chosen, the balance between benefits and risks must be weighed for each individual. Women often think the risks are higher than they actually are, yet OCs are safer for most women than pregnancy. The method has many benefits in addition to safe, reliable contraception. OCs result in regular menses and decreased flow, premenstrual syndrome, and dysmenorrhea, reduced acne, and improved bone density. COCs also provide a lifetime risk reduction for ovarian and uterine cancer. OCs should not be used by women who have certain medical complications. Smoking significantly increases complications for women of all ages. Women who smoke and are over the age of 35 years should not use estrogen containing contraceptives. Women who have previously smoked must abstain from all sources of nicotine for at least 6 to 12 months to be considered a non-smoker. Taking any COC increases the risk for venous thromboembolism, and therefore their use should be avoided in women with risk factors for that condition. Critical to remember: cautions in using combined oral contraceptives. Combined oral contraceptives should not be used by women with a history of any of the following: thrombophlebitis and thromboembolic disorders, cerebrovascular or cardiovascular diseases, estrogen-dependent cancer or breast cancer, benign or malignant liver tumors, hypertension unless well controlled by medication, migraines with aura or migraines in women older than 35 years of age, diabetes longer than 20 years or with vascular or other organ involvement. Combined oral contraceptives should not be used by women who currently have any of the following: any of the previously listed conditions: impaired liver function, suspected or known pregnancy, undiagnosed vaginal bleeding, cigarette smoking in women older than 35 years, major surgery requiring prolonged immobilization. Hazards are decreased by carefully screening for risk factors in each woman and the nurse's familiarity of the CDC-MEC. Obese women may have a higher risk for thromboembolic problems, but this is not considered a contradiction to OC use. Evidence is inconsistent about whether body weight affects OC effectiveness. Women with diabetes of less than 20 years duration who do not smoke and are in good health may use OCs with adequate supervision of their condition. OCs provide no protection against STDs. A woman should be advised to have her partner use condoms and spermicide if he may be infected or the relationship is not monogamous. Side effects: approximately 33% of women who do not wish to become pregnant discontinue COCs within the first year, usually because of side effects. Most side effects are minor and include signs and symptoms often seen in pregnancy. Using a different formulation of hormones may reduce some side effects. For example, decreasing the amount of estrogen helps relieve nausea and breast tenderness. Breakthrough bleeding occurs most often in the first 3 months and then usually subsides. If it is a problem, a COC with a different level or type of hormones can be used to decrease bleeding. Some women complain of weight gain while taking OCs, but studies have not shown it to be caused by the pills. Other side effects include fluid retention, amenorrhea, and melasma. Side effects often decrease after the first few months of use and are less frequent in low-dose OCs. Teaching: many unintended pregnancies result from failure to carefully follow instructions for the use of OCs. However, education about proper use greatly increases effectiveness. Teaching should be extensive when the woman begins to use the hormones. Follow-up is necessary to ensure her questions are answered and unanticipated problems resolved. Because the instructions can be complex, they should be written clearly and simply in her own language, if she can read. Teaching about when to start taking OCs is especially important. Methods of beginning OC use include the following. Quick start: the woman takes the first pill on the day the pills are prescribed if it is reasonably certain that she is not pregnant. A backup method is needed for the first 7 days of the first cycle unless her period started 5 days ago or less. This method is preferred because it provides immediate protection and may improve continuation. It avoids a delay during which a pregnancy might occur. First day start. The first pill is taken on the first day of the next menstrual period. No backup method is needed. Sunday start. Pills are begun on the first Sunday after menses begins. With this method, the woman avoids having a period on the weekend. A backup method is used for the first 7 days of the first cycle. The nurse should listen carefully to the woman's concerns about side effects and help her find methods of management. One study showed that women who did not fully understand the advantages of OCs and had low confidence in their ability to use them were less likely to continue use at 6 months. When women discontinue OCs because of these side effects, they may not use another contraceptive or may use one that is less effective and become pregnant as a result. Women should be instructed to keep a backup contraceptive method or emergency contraception readily available in case they decide to stop taking their OCs. It is essential that nurses be honest about the side effects that should be expected with all contraceptives. Teaching about temporary side effects may help the woman endure them until they are no longer present. Women should know that spotting is a common side effect of many hormonal contraceptive methods, particularly in the beginning. Over time, spotting may diminish or amenorrhea may develop. If changes in bleeding patterns or irregularity are unacceptable to the woman, she should choose another contraceptive method. Consistent daily ingestion. Maintaining a constant blood hormone level is important for effectiveness, especially with POPs. Therefore, the woman must take the pills near the same time each day. Many women make them a part of their bedtime routine. Others take their OCs with a meal to avoid nausea. And some take their OCs when they brush their teeth in the morning. Breakthrough bleeding is more likely when a significant time variation occurs between doses. Women should understand that some pills must be taken in a certain order and that changing the order will decrease the effectiveness of the method. Illness may affect the blood hormone levels. A woman who experiences vomiting or diarrhea should use a backup method of contraception for 7 days because the hormones may not have been properly absorbed. Missed doses. Instructions for the woman who misses one or more doses should be provided. Women who frequently miss OCs should be counseled about other contraceptive methods that might be more effective for them. The woman should follow instructions from her provider if she misses doses of her OC. Instructions may vary according to the type of OC used, the number of doses missed, and the time in the cycle the OC is missed. The woman who misses pills early in the cycle is at higher risk for ovulating. Different healthcare providers may use different regimens. See patient teaching, what to do if an oral contraceptive dose is missed, for an example of instructions. If a woman misses a period and thinks she may be pregnant because she missed one or more doses, she should take a pregnancy test immediately. Using another contraceptive method during this time is essential. However, there is no association between inadvertently taking OCs when pregnant and fetal complications. Postpartum and lactation. COCs increase the risk for VTE and reduce milk production in lactating women, and very small amounts may be transferred to the milk. All postpartum women should avoid COCs for 3 weeks after giving birth, and lactating women should avoid COCs for 4 weeks. Progestin-only OCs may be a better choice if a woman wishes to use a hormonal contraceptive because these OCs do not affect milk quantity or quality. There is no evidence of adverse effects on the infant, and no waiting period is required. Medications. OCs may interact with other medications, and the effectiveness of each may be changed. Some may increase or decrease estrogen or progesterone levels. OCs may interact with some anticonvulsants, which may be used for seizure disorder or psychiatric illnesses, antiretroviral drugs, and rifampin for tuberculosis. Over-the-counter drugs should also be considered. For example, St. John's wort, which some women take for depression, interferes with OC effectiveness. Because of these various interactions, the woman should always tell her healthcare providers and her pharmacist about other drugs or supplements she is taking. Follow-up. The only essential follow-up for women who take OCs is yearly blood pressure measurement. It is not necessary for women to have yearly pelvic examinations, Pap tests, or breast examinations to receive prescriptions for OCs. Women using OCs should follow the same recommendations as those for women who do not take OCs. During the follow-up visit, the woman's ability to remember to take a pill every day should be evaluated. Other methods should be discussed if remembering is a problem or if she wants to change methods. Return of fertility is rapid after the pills are discontinued. A woman may wish to wait until her menstrual cycle is reestablished before conceiving so that she can date the beginning of her pregnancy more accurately. She should be advised to take folic acid for several months before becoming pregnant to help prevent neural tube defects in the fetus. The woman should report any signs of adverse reactions immediately. Use of the acronym ACE may help the woman remember signs that may indicate complications. Emergency contraception. Emergency contraception, EC, often called the morning after pill, is a method to prevent pregnancy after unprotected intercourse. EC may be used after contraceptive failure, such as a condom breaking during intercourse, or when a woman misses too many OCs. It also may be used after rape or in other situations in which contraceptives were used incorrectly or not at all. 3 forms of EC, Plan B 1 step, next choice 1 dose, contain the progestin levonorgestrel. In the past, EC was available at pharmacies without a prescription for women aged 17 years and older, but those younger than 17 years needed a prescription. In 2013, a federal court decision declared Plan B 1 step should be available to women and men of all ages without a prescription. The progestin-only ECs work by delaying or inhibiting ovulation, thickening cervical mucus, and interfering with the function of the corpus luteum. The treatment is ineffective if implantation has already occurred, and it does not harm a developing fetus. Another form of EC is alipristal acetate, ELA, which requires a prescription for all ages. ELA acts to delay or block the surge of luteinizing hormone and ovulation. It also may inhibit implantation and requires a pregnancy test before use because it may disrupt an early pregnancy. The most common method of EC involves taking 1, Plan B 1 step, next choice 1 dose, or 2, next choice tablets taken together that contain a high dose of progestin. The pills should be taken as soon as possible or up to 120 hours after unprotected intercourse. EC will not prevent pregnancy if unprotected intercourse occurs after EC is used. COCs may also be used in larger than usual doses to prevent pregnancy. The number of tablets varies according to the specific COC used, and this method should only be used under the guidance and recommendation of a healthcare provider. This method may cause nausea, so women are often advised to take an antiemetic before taking the pills. Insertion of the copper T380A IUD within 5 days of intercourse also may be used and provides 99% effectiveness. It has the added advantage of providing long-term 10-year protection from pregnancy for those who choose this method. Although EC is available, use is suboptimal. Many women are unaware of the availability of EC, and those who are do not always use it to prevent unintended pregnancies. Women may not know how or where to get it. Information about EC and how to obtain it should be included whenever education about contraception is offered to women in case they might later wish to use it. The Association of Women's Health Obstetric and Neonatal Nurses, AHWAN, states that nurses should ensure that women receive information about all type of contraception, including how to obtain emergency contraception. Women who need EC should receive counseling about their regular contraceptive method. They may not understand how to use their method correctly or may wish information about other, more effective options. Because of the short time frame during which EC is effective, some healthcare providers give women prescriptions to use at a later date if they should need it. Information about where EC can be obtained is available on the internet. Women who use EC have not been shown to be more likely to have risky sex, future unplanned pregnancies, or STDs. Transdermal contraceptive patch. The transdermal contraceptive patch, Ortho Evra, releases small amounts of estrogen, ethinyl estriadol, and progestin, norelgestromin, which are absorbed through the skin to suppress ovulation and thicken cervical mucus. It also regulates menstrual cycles. The contraceptive patch is as effective as OCs, or it even may be more effective because it is used once a week instead of daily. A non-hormonal contraceptive should be used during the first week of use, unless the patch is started within the first 5 days of the menstrual period. For most users, fertility returns quickly, with hormone levels back to normal within 1 month of discontinuing the patch. The patch is applied to clean, dry, non-irritated skin on the abdomen, buttock, upper outer arm, or upper torso, including the breasts. Areas where clothing such as straps or waistbands may rub, the patch should not be used. The woman should avoid using oils or lotions in the area because the patch may not stick. Adherence to the skin is good even in the shower or when exercising or swimming. The patch should not be cut or altered, and no more than one patch should be worn at a time. A new patch is applied to a different site weekly on the same day of the week for 3 weeks and worn continuously for 7 days. Then the patch is removed for 1 week. During the patch-free week, the woman has a period. After 7 patch-free days, she applies a new patch and begins the cycle again. Women can have extended cycles without menses by using patches for several cycles or continuously. Side effects include spotting, breast tenderness, headaches, and skin reactions. Other side effects and risks are similar to those for COCs. The patch has been found to be less effective in women who weigh more than 198 pounds, 90 kilograms. The risk for VTE is higher with patch use than with OC use because total exposure to estrogen is greater. However, studies have had conflicting results. The risk for VTE is less than that for pregnancy, but women with risk factors for VTE should discuss the risks and benefits of patch use with their healthcare provider. Because the patch must be applied only once a week, it may be easier than OCs for women who have difficulty remembering to take a pill every day. However, it is visible on the skin, which may be a problem for adolescents who do not want their contraceptive use known by others. If a patch detaches, the woman should try to reattach it. If it will not adhere again, she should replace it with a new patch. She should not use tape to keep it on, because the contraceptive is in the glue of the patch. No backup contraception is necessary. If the patch is off 2 or more days, or she is 2 or more days late in changing the first or second patch, the woman should apply a new one and use backup for 7 days. If the woman is 2 or more days late in changing the patch in the 3rd patch week, a new one should be applied. She should omit the patch-free week and start a new patch cycle. Contraceptive vaginal ring. Women using the vaginal contraceptive ring, NuvaRing, insert a soft, flexible vinyl ring into the vagina and leave it in place for 3 weeks. The ring, which measures 5 centimeters, 2 inches, in diameter, and is 4 millimeters thick, releases small amounts of progestin and estrogen continuously to prevent ovulation. The woman removes the ring at the end of the third week and withdrawal bleeding occurs. A new ring is inserted to begin the next cycle 1 week after the old ring was removed. Although a prescription is required, no fitting or particular placement in the vagina is necessary. There is no need to think about contraception except twice a month when the ring is being placed or removed. Women must be comfortable inserting the device into the vagina. Placement and removal are quick and easy. Allowing a woman to try replacing the ring in the provider's office, where help is available, often increases confidence. For the woman who does not want her contraceptive use known by others, the fact that the ring is not visible is appealing. Use can begin during the first 5 days of the menstrual cycle, even if the woman is still bleeding or on any other day. A backup contraceptive is necessary for the first 7 days of the first cycle if the ring is inserted on any day but the first 5 days of menses. The most common side effects are headaches, breast tenderness, and nausea, similar to those of COCs. Other side effects include vaginitis, expulsion, or vaginal discharge or discomfort. Although some women or their partners can feel the ring during intercourse, it is generally not a problem. Breakthrough bleeding is less common than with OCs. Women who should not use hormonal contraceptives also should not use the vaginal ring. The ring may be removed for up to 3 hours without loss or effectiveness. If 48 or more hours without the ring occurs in the first 2 weeks, the ring should be reinserted and a backup method used for 7 days. If the ring is out of the vagina for 48 or more hours in the third week, the woman can leave it out and have a withdrawal bleed or insert a new ring. Omit the ring-free week and start a new cycle of ring use. If the woman desires extended cycles, she can insert a new ring when she removes the old one and avoid the withdrawal bleeding. Barrier methods. Barrier methods of contraception involve chemicals or devices that prevent sperm from entering the cervix. The method may kill the sperm or place a temporary partition between the penis and the cervix. All barrier methods are coitus related and may interfere with spontaneity. They avoid the use of systemic hormones, however, and provide some protection from STDs. Chemicals that kill sperm are called spermicides and are available in many forms. Creams and gels are generally used with mechanical barriers, such as the diaphragm or the cervical cap. Foams, foaming tablets, suppositories, and vaginal film may be used alone or with another contraceptive. They are inserted deep into the vagina about 15 minutes before sexual intercourse, so they are in contact with the cervix. Vaginal films and suppositories must melt before they become effective, which takes approximately 15 minutes. Spermicides are generally effective for less than 1 hour. They should be reapplied if intercourse is repeated. Women should not douche for at least 6 hours after intercourse. Spermicides are readily available without a prescription, inexpensive, and easy to use. Using spermicides increases lubrication, which decreases the risk for condom breakage. This is an advantage, especially during lactation or in menopause, when vaginal secretions are decreased. Effectiveness is increased when spermicides are used with a mechanical barrier method. Some women and their partners think spermicides are messy and interfere with the sensation during intercourse. Some women also may experience a vaginal sensitivity to spermicide that may cause burning. Frequent use, 2 or more times a day, or sensitivity to the products may cause genital irritation, which could increase susceptibility to infections, including HIV infection. Spermicides do not protect against STDs and should not be used for that purpose. Mechanical barriers. Mechanical barriers are devices placed over the penis or the cervix to prevent passage of sperm into the uterus. They include the condom, sponge, diaphragm, and cervical cap. Male condom. Condoms, the only male contraceptive device currently available, are the third most popular method of contraception in the United States and are used by almost 9 million couples. They cover the penis to prevent sperm from entering the vagina. Condoms are most often made of latex and may be coated with a lubricant. Latex condoms provide the best protection available, other than abstinence, against STDs, including HIV infection. For this reason, condoms should be used during any possible exposure to an STD, even if another contraceptive technique is practiced or the woman is pregnant. People who are allergic to latex should avoid the use of latex condoms because severe reactions are possible. They may use only polyurethane or natural membrane condoms instead. Polyurethane condoms are thinner than latex but may require lubrication to avoid breakage and are more likely to slip off. Natural membrane condoms do not prevent passage of organisms that may cause STDs. Condoms are readily available, are inexpensive, and can be carried inconspicuously by the man or the woman. The typical failure rate can be decreased by combining condom use with another method such as vaginal spermicide. Reservoir tips and water-based lubricants help prevent breakage. The slippage and breakage rate is approximately 5 to 8%. Because condoms must be applied just before intercourse, some couples object to the interference with spontaneity. Others think condoms interfere with sensation. Men with erectile dysfunction may have problems with condom slippage. Condoms may be affected by vaginal medications or lubricants, and they should not be used concurrently. Only water-based lubricants should be used for latex condoms because oil-based lubricants will cause deterioration of the latex. Female condom. The female condom, also called a vaginal pouch, is a polyurethane sheath inserted into the vagina. A flexible ring inside the closed end of the condom fits over the cervix like a diaphragm. Another ring extends outside the vagina to partially cover the perineum. The female condom is the first contraceptive device that allows a woman some protection from STDs without relying on the male condom. Male and female condoms should not be used together because they may adhere to each other. Sponge. The contraceptive sponge, today, is made of soft polyurethane that traps and absorbs semen and contains the spermicide nanoxynol 9. The sponge is approximately 5 centimeters, 2 inches, in diameter and provides contraception for 24 hours without the need to add spermicide for repeated intercourse. It does not require a prescription, contains no hormones, is easy to use, and can be inserted just before intercourse or hours ahead of time. To use the sponge, the woman washes her hands and wets the sponge with about 2 tablespoons of water, squeezing the sponge until it becomes sudsy. She then folds the sponge with the concave dimple area inside and the loop on the outside of the fold and inserts it into the vagina. When the sponge is released, the dimple covers the cervix and helps keep the sponge in place during intercourse. To eliminate interference with spontaneity, some women insert the sponge hours in advance when intercourse is anticipated. Repeated intercourse does not require added spermicide or a new sponge. It should remain in place for at least 6 hours after the last intercourse. It is removed by inserting a finger into the loop and pulling slowly. The sponge should not be used during menstruation or left in the vagina for more than 24 to 30 hours because of an increased risk for toxic shock syndrome. It should not be used by women with a history of toxic shock syndrome, and it does not protect against STDs. The sponge may cause irritation or be difficult to remove for some women. Diaphragm. The diaphragm is a latex dome surrounded by a spring or coil. The woman places spermicidal cream or gel into the dome and around the rim and then inserts the diaphragm over the cervix. Because it covers the cervix, the diaphragm prevents passage of sperm while holding spermicide in place for additional protection. Traditional diaphragms must be fitted by a healthcare provider, but in most cases they are no longer available in the United States. Currently, a one-size-fits-most-women diaphragm, KEA, is commercially available and is covered under most insurance plans. All diaphragms should not be used for the first 6 weeks after delivery. Pressure on the urethra from a diaphragm may cause irritation and urinary tract infections. Voiding after intercourse may help prevent infections. An allergy to latex or a history of toxic shock syndrome precludes use. The diaphragm may be damaged by oil-based lubricants and some medications used for vaginal infections. Cervical cap. The cervical cap, femcap, is a cup-like device placed over the cervix to prevent sperm from entering. It is similar to the diaphragm, but smaller and must be fitted by a healthcare provider. The flexible silicone cap is inserted over the cervix after placing spermicide on both sides. It stays in place by suction. The cap does not cause pressure on the bladder and can remain in place for 48 hours. More spermicide is inserted into the vagina without removing the cap if intercourse is repeated. The nurse should teach the woman to feel her cervix to check placement before and after intercourse because the cap can become dislodged. Cervical caps should not be removed for 8 hours after the last intercourse. The cap has a loop to assist in removal. Caps should not be used during menses or in women with a history of toxic shock syndrome. Cap sizes are based on whether the woman has had past pregnancies and births. Natural family planning methods. Natural family planning methods, also called fertility awareness or periodic abstinence methods, use physiologic cues to predict ovulation so women can determine when conditions are favorable for fertilization. These methods can help women who wish to become pregnant or avoid it. Natural family planning helps women learn about how their bodies change throughout the menstrual cycle. It is acceptable to most religious groups and avoids the use of drugs, chemicals, and devices. Couples must be highly motivated to use these methods because they must abstain from intercourse during as much as half the menstrual cycle. The method is very unforgiving, and errors in predicting ovulation may lead to pregnancy from intercourse during the fertile time. Some women use the method to determine when they are fertile and use a barrier contraceptive at the time. Calendar. The calendar method is based on the timing of ovulation approximately 14 days before the onset of menses. The couple must abstain or use another method during the days calculated to be fertile. The method is unreliable because many factors such as illness or stress can affect the time of ovulation. Standard days method. This method uses a string of color-coded beads to help keep track of the fertile and infertile days of each cycle. The woman begins with the first bead on the first day of menses. The method is designed for women with cycles that vary from 26 to 32 days in length, but is ineffective for other women. Days 8 through 19 are considered fertile days. Symptothermal method. The symptothermal method combines assessment of basal body temperature, BBT, body temperature at rest, and cervical mucus daily. In addition, symptoms that occur near ovulation, such as weight gain, abdominal bloating, middle schmerz, pain on ovulation, and increased libido are noted. This increases awareness of when ovulation occurs and increases effectiveness. Some women also use an electronic hormonal fertility monitor. It is designed for women trying to become pregnant, but also can be used by women to avoid pregnancy by identifying fertile times. Abstinence. Abstinence is avoidance of sexual intercourse and any activity that may allow sperm to enter the vagina. Although it is the only completely effective method of preventing pregnancy and most STDs, abstinence requires perfect use to be effective. Depending on the time within the menstrual cycle it occurs, intercourse without the use of a contraceptive has up to an 85% chance of resulting in pregnancy. Most women are not abstinent all of their reproductive lives, but many practice abstinence at various intervals. Some women practice abstinence part of the time, but have other methods available to use if they decide to become sexually active. Periodic abstinence is also practiced by women using the natural family planning methods. Nurses should support women who choose to be abstinent. Sexual education programs in schools often include information on ways to maintain abstinence. Abstinence-only education programs have not been successful in reducing teen pregnancy. Adolescents who choose abstinence need assistance to define their values and learn practical methods of reaching their goal. They need to consider just what this entails and when it might be difficult to maintain abstinence. Role-playing often is used to help them work through what to do and say before it becomes necessary. Abstinence has no cost, avoids the use of hormones, and has no side effects or medical risks. It is important that users understand that abstinence must include all forms of sexual contact, including oral and anal intercourse, to avoid exposure to most STDs. Women using abstinence should know where to get information and contraception if they decide to become sexually active at a later time. Least reliable methods of contraception. The methods of contraception discussed in the following section are not considered reliable, but are used by women who lack information about their risks and other options, or who do not wish to use other methods for medical or personal reasons. The nurse needs to be familiar with these methods to help women understand the risks involved. Lactational amenorrhea. Breastfeeding inhibits ovulation because suckling and prolactin interfere with secretion of gonadotropin-releasing hormone and luteinizing hormone. During lactation, the ovarian response to follicle-stimulating hormone and luteinizing hormone may be altered. The frequency, intensity, and duration of suckling are very important in inhibiting ovulation. Women who breastfeed fully with no supplementary feedings may avoid ovulation and resumption of menstrual cycles. However, use of formula or solid foods decreases the frequency and duration of breastfeeding, increases the length of time between feedings, and reduces night feedings. This may lead to ovulation and a return of menses. The menstrual cycle generally resumes by 6 months, even in women who breastfeed fully. Another method of contraception should be used by that time or earlier if menses has resumed or supplementary feedings are used. Coitus interruptus. Also called withdrawal, coitus interruptus is the removal of the penis from the vagina before ejaculation. The method requires great control by the man and may be unsatisfying to both partners. Even a man who wishes to use the method may misjudge the timing and withdraw too late. It is important to remember that pre-ejaculate fluid may contain sperm and that sperm spilled near the vaginal opening may enter the vagina and cause pregnancy. Application of the nursing process. Choosing a contraceptive method. Contraceptive failure often occurs because women lack knowledge about how to use their contraceptive methods correctly or choose methods unsuited to their needs. When contraception fails, the woman is exposed to the physical, psychological, and social consequences of unintended pregnancy. Lack of understanding also may expose her to unnecessary side effects, possible complications, or STDs. Assessment. Because contraception is a very private matter, approach it in a sensitive manner. Perform the assessment in a quiet area where interruptions are unlikely, and keep voices low to increase the woman's comfort. Assure the woman that her confidentiality will be maintained. Introducing the subject. In the postpartum setting, introduce the subject by asking the woman if she plans to have more children. Most women indicate a desire to wait a certain period before the next pregnancy. Ask the woman, what method of family planning are you thinking about using now? Or, how did you feel about the method you used before pregnancy? These questions may identify problems that the woman has had with contraception in the past. Introduce the topic during well-woman checkups by asking about the woman's current contraceptive method and if her needs have changed. In other settings, a woman may make some reference to her contraceptive method. The nurse can respond by asking her, how do you like using name method? This shows the nurse is interested if the woman wishes to pursue the topic. Determining the woman's understanding. Determine the woman's understanding of her contraceptive technique. For example, ask where she places her patch, or if it is hard for her to remember to take her OC each day. The woman should know how to use her technique effectively and what to do in special circumstances, such as when she misses an OC pill. Explore any misinformation, concerns, or problems she may have with regard to effectiveness, technique, or common side effects of the method. Assessing the woman's satisfaction. Assess the woman's satisfaction with her contraceptive. Women may be unsure about their method in the early months till they gain comfort from repetitive use. Satisfaction and effectiveness increase with greater familiarity with the method. Side effects also affect satisfaction. They may be severe enough to cause the woman to consider another method, or they may be relieved by simple techniques. Talking about side effects helps differentiate serious complications from minor effects and lead to a discussion of relief methods. Assessing appropriate choices. If the woman is considering a change in contraceptive method, assess factors that would help determine the best method for her. Include a history of medical conditions that might eliminate certain methods, childbearing history, cultural and religious beliefs, and intensity of her desire to prevent pregnancy. The woman's ability to understand and follow complex directions is important as well. The couple's relationship is important in terms of contraceptive choice and protection against STDs. If the relationship is mutually monogamous and neither partner is infected, STDs may not be a risk. If there is a possibility that either member of the couple is infected or has more than one partner, condom use is essential, even if the woman uses another type of contraceptive. Frequency of coitus may help determine the best choice of contraception. For occasional sexual intercourse, a barrier method may be most satisfactory. If intercourse is frequent, the woman may desire a method that is always in place, such as an IUD or a hormone implant. Explore her past experience with other methods, what she considers important, and her individual preferences. Identification of patient problems. Inadequate knowledge about family planning is common. Many women will have a need for patient teaching due to a lack of understanding about contraceptive methods. Planning expected outcomes. Expected outcomes for this diagnosis are that the woman will do the following: correctly describe how to use her contraceptive method, including solving common problems. Describe common side effects, signs of complications, and correct follow-up. Report that she and her partner are satisfied with their contraceptive method or explore choosing another method. Interventions. Interventions involve teaching about contraceptive techniques and follow-up of problems that may interfere with the woman's ability to maintain health. Increasing understanding of the chosen method. Fill in gaps in the woman's knowledge about how her contraceptive method works, its effectiveness, advantages and disadvantages, common side effects and complications, and when to seek help. Use demonstrations, such as applying a patch or inserting a vaginal ring, and return demonstrations for using the method. Give suggestions for managing side effects and common problems. Understanding common side effects and how to manage them often helps women continue to use the method. Teaching about other methods. Provide information about other forms of contraceptives, if the woman wishes. Discuss characteristics of methods that are most important to the woman and her lifestyle. Compare other methods with the one she is currently using. Talk about benefits, disadvantages, and risks so that she can make an informed choice. If a prescription, insertion, or fitting is needed for a new method, discuss what may happen during the visit. Provide written information she can take home to review and discuss with her partners, if she wishes, before making a final decision. Protecting against sexually transmitted diseases. Address defense against STDs, particularly if the woman is using a method that does not provide protection. A way to approach it might be to say, the method you are using is very effective against pregnancy but does not protect you against diseases such as HIV infection that you might catch from a partner. If there is any chance that you or your partner might have sex with someone other than each other, or that your partner might have an infection, you should protect yourself by using condoms along with your regular contraceptive, including the woman's partner. Invite the woman to include her partner in the discussions if possible. He may influence the woman's choice of contraception and whether she actually uses it and uses it correctly. If the partner understands the proper method of use, he may be more cooperative and willing to help ensure contraceptive success. Providing ongoing teaching. Instruct the woman to call if she has any questions or difficulties. If she chooses a new contraceptive, suggest that she visit again in 1 to 2 months to discuss her satisfaction with it. Make a note in the chart to discuss contraception at her next visit, even if the visit is for another reason. Evaluation. The woman should explain her contraceptive method, including ways to solve common problems and when to seek help for side effects or complications. At later visits, evaluate continued understanding, compliance with proper use, and satisfaction with the method. The woman who wishes to change her contraceptive method should describe other contraceptives available and how they should be used. She should choose a new method and, if necessary, visit a healthcare provider for further discussion, examination, fitting, or prescription.